well, I mean, you can either choose to practice an emergency UV, but I mean, more likely this is going to be like your stabilization UV, right? Like maybe, you know, you got a baby who needs antibiotics and team's stuck and you know, you just can't get an IV, so you're going to put in the nurses are bugging you. Please just stop poking this baby and put in a UV. They're like, no, I don't want to have to. It's so hot under the lamp.
That's so true.
Okay, so like this, in terms of equipment, you're going to open your UV tray.
Yes.
You're going to pick your line.
Yep.
I don't know
and
what you
we
guys...
have those double ones now too.
Perfect.
So yeah.
Essentially for the term baby, right? 5 French.
Yes.
Right? That's what you're going to use.
And I'll just
So, and then, like, yeah, so sterile procedure, easiest to have someone else. I feel like this is like slightly different than what we have.
Okay.
You got real ones?
Yeah, so Danielle, we got them. Yeah.
Oh my goodness.
So Lisa, right, I'm correct here, right? We've got our right.
Yeah, and again, there isn't any nurses in this group, so
Do you have a flush there? Yeah, let's steal this flush.
you can pretend. That's a chickeny one.
Right.
I'm trying to keep chicken separate from, just can we pretend that is all?
Yeah, although I wonder just
If there's
some
any
water?
actual
Is there water somewhere?
Oh, yeah, I see it over here. Oh, here.
Well, just see which one is sort of a little bit.
That's your mark. So this is actually in the hub. Exactly.
Because it would be at 2 and 10 if it's close to the baby, right? The arteries tend to be at 2 and 10. If you're lost, if you can't figure it out.
Yeah.
It's usually pretty obvious.
Yeah, that one's not obvious.
No,
though.
no, it isn't.
That one
Right?
is.
Yeah.
That one's obvious.
This is the fun about practicing on real cords.
Yeah.
Remember the one that Bav did the first time? It was like the most challenging chord. But
yeah.
like, she's one of our new grads, and we did like a whole session with real chords.
Oh,
and
yeah?
she told me afterwards, she was like, you know what? Like, that actually super improved my skills. Like, she's done really well since then with her UV
She got,
insertions.
here. Oh, is
Tiny
this
little-
our? Okay, just help me out.
That's a double.
But are we not mostly putting in doubles?
Nope, we mostly put in singles.
Okay, thank you.
But that looks tiny, like a 3.5.
Yeah.
Yeah. So you might just have to put in the 5 double.
That one, yeah. No, I've never seen one so small.
So let's see. Like, so sterile procedure. You've got your stuff. You're gonna flush your line as like step 1. We usually put stopcocks on these guys. No, we put these things. What are these things called?
So it's you guys have different equipment to us.
That's one that you just picked up. That's
Okay.
one Linky's brought this into our life.
So this is what we use in Nanaimo and Victoria now for our indwelling UVs. So this, your nurse is gonna like, our nurses generally set up the sterile field as the physician is like doing their stuff.
Reviewing the procedure.
We can pretend that this is a single
Yeah,
line,
pretend this is a single lumen.
and then just flush the whole.
So yeah, you want to flush the whole line, right, so that you see. And again, you're sterile at this stage.
Have your doodah ready.
And then you're gonna put it on your tray, ready to go.
Great.
So we talked about sizing. We don't need sedation for this. You know, consideration of talking to parents about getting consent, but it depends on the acuity. You're going to clean your area. So this, I'm sure, I'll just go over it but I think you guys know, right? But typically you would have a clamp on here, right? And so you're going to clip this on the clamp. You're going to hand this to your assistant, who's going to hold this while you clean the cord.
Clamping on the vein, like you're holding the vein.
You're actually holding. No, this is clamping on the Lico clamp.
Yeah.
Oh, I see.
Yeah, because this. So then that just all that this does is holds it up. So you clean it and then you get your fresh cut. When you're getting your fresh cut, right? You don't want to cut it like this right against the skin. You want to like leave yourself, I think, a good centimeter or 2. But acknowledging you're going to need to consider that distance for insertion size, which is a good point. What do you guys use for the different ways to calculate how far to put it in, right?
You know what? I just got a little thing on my.
Perfect. Okay. Okay. So you guys have it. Yeah. So just like that's step 1 is how big's your baby, how far to put it in. Okay. So you've held it, you've cleaned it, you've cut it. We got to put our tie on, right? That's the part I didn't tell you. Silk tie. Yes. Over there, right? So you actually should do this like before you cut it, just because this is your safety, right?
Yes, absolutely.
And obviously tricks here, don't tie it too tight. You know, you just want to put, it's sitting there on it. It's just hard because there's nothing to go against here. So this is just going to kind of lie flush, but being mindful that if this is too tight and you say you can't get into you might want to loosen this guy. This is just if things start bleeding so you can clamp it off. Yeah.
It might not.
You might not need this. This is just your seatbelt. Put your seatbelt on. So then you've cut it. You've cleaned, tie, cut. So I like the technique of grabbing some little, and I never remember the name of everything, and clamping on the side and then rolling them out. So you can have two of them, because then they hold your tube open. It's a bit trickier to do that on these guys just because of working out of the thin air.
Just to open up the vein.
Yeah, so this just like kind of creates that counter traction to pull everything open. And then you can leave these to kind of hang there. Yeah, and the weight of them will sort of pull that open. But again, it's tricky here. You can try it, but you just might need one of us to hold it. And then
that's, you know, that's such a great technique, because normally I'm just kind of holding this just for traction.
Yeah, exactly.
And then I usually just get the little dilators.
Yeah.
And I never use these ones.
I don't use those either.
I'm not sure what those are. I think they might almost be like old clips. They almost look like clips where you'd clip it onto. But
now you've gone in 2 hours later. Everything was really good.
yeah, that's great.
Yeah.
I'll just see if.
Thanks for tracking now a little bit.
Yeah, and you want to find your spot.
I was just saying, this one is.
It's really hard.
You picked a hard one.
Maybe that's actually the thing. Yeah, it's finally open. There it is.
Oh yeah, there you go. Right. So then actually that technique works if we put another.
There we go. Yeah, that's actually, it's actually quite dilated.
Different.
Yeah,
Now.
that's good.
And let's say this is our heater.
Obviously when you put these on, you don't want to like grab the actual vessel.
Acorn
Oh, I don't think you need it.
No, that's
But you
okay.
could have the other one on there, right, to really hold it open.
We're going to grab that. So we would open up our first page with our acorn.
Oh, we might regret it now. Oh yeah, so there you go, perfect.
And like just kind of go
Yeah,
through each
unless I
one.
get into
So
a
you
false
wanna-
passage
so
or something,
Yeah.
which definitely can happen.
Totally.
Such a great little system.
The
Funny
thing I was
how-
watching sort of said like, you know, try and get it into 3 centimeters. Sometimes these guys I find like it's, get it into 3 centimeters and then sort of see if you can get some blood, and you're just going to push it in. Obviously if it's just low lying, you're just going to go a couple of centimeters in, then it's just going to be an emergency line. So, but not as stable, won't last as long, will have to be replaced.
Yeah, I just think I'm in a.
Yeah. I feel like you picked the tricky chord. The
okay.
struggle I always have is it bouncing off the liver, right? So then it's just taken the wrong turn.
Yes.
So some tricks is like, number one, if you find that, is like to pull back until you got, and then sometimes to, as you advance, flush as you advance. So then hoping you'll sort of like, you know, you'll take the right hand turn instead of the left. Another technique is to push on the liver with one hand while you advance.
Put some resistance on that side.
Yeah, so that sort of should just close those venous vessels, right, a little bit, so that you can go up. Sometimes if you've got one in there and you're like, oh, it's just bouncing, you feel that, you can leave that one in and then insert a second one behind it, hoping that that first one will block. Yeah.
Like a dilator.
Yeah. And sometimes like rotating as you go in. So those are sort of like the 4 tricks. Flush as you go in, rotate as you go in, pressure on the liver, and then
Does this feel
eventually,
like a fresh cord to you, or is it harder on a cold cord?
or second line behind it. Yeah.
Yeah, it feels this track feels good, and then I sort of get to
I wonder if giving you the second.
let's
Here, why don't I hold this
Yeah,
and,
that's
and you
great.
put a second set of things on, and then I can hold.
That's with no respiratory support. And,
I do feel like these may be harder than real life, but which is maybe good. Or maybe
yeah,
not good.
exactly.
so the acorn
Thank
sequence
you.
kind of guides us.
Sometimes I'll also like move the cord, like if I sort of pull back, and then I'll move the cord a certain way and then try. I don't know. Those are all my tricks because I tend to be the liver person.
So now we're moving on.
I feel like almost everyone hits the
I know.
It's so hard not to.
I find a lot of times if I do like get a false track, I usually do cut it fairly long, and then
Yeah.
I'll recut
Yes,
it.
that's a
and
good
it's
point.
so weird. It
Yeah.
just seems to
Yeah,
often
no,
work
totally,
that-
because it's almost like it's just so soft through the actual cord.
Yeah.
And then you want to, we can talk about placement, like how to secure it after, but obviously you're also going to do an x-ray to confirm
Yes.
placement. And you want to see it like sort of in the IVC near the RA, which is sort of that T6 to 9 location. Sorry, low, you're seeing it as L3.
And then as long as you've had your x-ray confirmation, then you can begin your infusion. We always do 2 x-rays, always, for central lines and for lines. So AP and
Before you
lateral.
start any antibiotics
Before
or
you start
anything.
anything. Always
Yeah.
an AP and lateral every single time. Always.
Don't anyone tell you otherwise.
Don't let anyone tell you
Because someone was
otherwise.
told that one doctor said, no, just go ahead. Like, no,
No,
we have to have
don't do it.
Yeah.
Let me tell you about a baby that almost died. It's seriously like things that you can't see AP, like pneumos. Like when you're doing a chest X-ray for a respiratory kid, AP and lateral. Always.
Every time.
You will almost. I can't even count the amount of times where you will not see a pneumo AP, and then you'll look lateral and you're like, whoa, there she is. Always. I actually think it's a VHOP policy now because of situations that have happened with central lines that have not been x-rayed laterally.
Yeah.
Weird things can happen, and when you don't look at it sideways, you will miss them, and it's not good. So yeah, AP and lateral chest x-ray, we're like, whoo, we're past the liver, or you can't get past the liver, but you're happy with a low line for now. And then as long as it looks good, then you're gonna like hook up all your, that's already gonna be done. We just sit here. I mean, sometimes we sit here for like, I don't know, however long it takes, and just intermittently flushing our line until we're ready to like hook up our infusions and everything. And then once we're ready, then we just like hook it all up. We actually rarely put double lumens in, but they're not unhandy to have, truly. We'll only do it for like our sickest babies. And I think that's kind of it.
That's good. And do you use an umbilical tray like this, that what we have, or is there yours?
Ours looks a little, it has sort of like the same kind of thingies, but it also has like a little thing on it, a little cup, and maybe another little basin. Yeah, very similar. We use those trays, like I said, for everything. We use them for our umbilical lines and our chest tubes.
Yeah. Right.
And I feel like that's probably the biggest thing for nursing, if you're unfamiliar with the procedure, is like the actual setup and the preparation for it. Because the physician really is like doing the job, but it's like you have to remember like which pieces and where do they go. And
Yeah, I like that we can use that for, like, just take our umbilical tray out for chest tubes too. So.
Yeah, that's what we
that's what we
that's what we do. There's like things on there that you can use, and plus it's sterile, and then you have like a nice solid sterile field that you can drop all your stuff onto, and it's like lipped too, which is nice because we always use like we have 2 radiant warmers in our resuscitation room, and so we just like wheel out a metal trolley which is flat, and so it's nice to have like a lipped tray so that things aren't falling off of them. Yeah, that's great. Does anyone want to like physically go over the Neil bridge, like do the Neil bridge?
And like our IVs, like we do our site to source checks hourly, right? So we clear our total, so we do our hourly checks where we check our measurements, that it hasn't been pulled
That had migrated.
or migrated.
Yeah.
Exactly.
Yeah, getting that number. So.
Yeah, getting the number right. And so
Yeah.
when Lisa taped it, like she made sure that she left a
could
few
see the
numbers so you
numbers.
could have something. Because if you sort of just do it without that, sometimes you'll get it all taped down and you're like, I don't see anything. And then you're making your own with a Sharpie. And
I know,
oh
it's
my
like,
gosh.
oh gosh, yeah.
And tips and tricks for like oozing, like we use Surgisil. If it will continue to ooze after like pressure, first we'll do pressure.
Some pointers about, like, so say we are in a situation where, okay, the umbilical line is coming out, so now you're taking it out, what, you just put like a little pressure dressing on that site now?
We do actually have a guideline and a procedure for that in VHOT. It's on the internet for
Okay,
removing a UVC and a UAC. The procedures are slightly different for each, but we rarely put UAs in, so I can't imagine you guys would be having them in.
No.
But yeah, there is a procedure online. Essentially, yes, you're sort of like one fluid kind of slow movement. You're gonna stop at the 5 centimeter mark, let it like vasoconstrict or spasm for a little bit, and then you're gonna like keep pulling it. UA is slightly different. You stop at 5 and then you go centimeter by centimeter every few minutes to allow it to like constrict behind the artery.
Okay, right.
But for a UV, you just would like wait at 5 centimeters and then pull, and then just pressure, and then they need to remain visible for 24 hours post removal.
Okay.
Yeah.
We don't put like anything on top of it after
so
it's
you just
out.
kind
We-
of put a little pressure for how, like a few minutes, or
Yeah, until
Yeah.
it's done. And some babies you're
You
doing
kinda,
in a
like,
couple of
eyeball it.
minutes. You're like,
Yeah.
oh, there's nothing. My gauze is clean after 3 minutes.
Yeah.
And there's others where you're holding it, you know, maybe for
Right.
5 or 6.
Right, okay.
And then, but then leaving it, we'll try to keep them supine or like maybe slightly sort of side lying, but mostly supine so that you can see it, because then you're still doing your like sight check, you know, hourly until you're
Right.
confident that it's. And if it is bleeding and oozing, that like
With the
we
line
will-
in.
yeah.
Which does happen quite a bit too. Like,
Yeah.
we'll try pressure first, and if pressure doesn't work, then we'll move to like Surgisil.
and then just a little,
A tiny bit.
just a
like
bit
a
of drop on it.
It's like
just-
a little mesh, the little mesh,
Yes.
and you cut
Yeah.
it, and you really
Yes.
don't need much. And I really think you're not supposed to use much. Like, it's like
Yeah.
use sparingly.
and you just kind of put it where you see the ooze.
Yeah, usually sort of like around
Around.
on the base of the stump, and it actually almost always solves the problem.
Yeah.
Is that the same as hemostat? That
Yes.
beta stuff?
Yes. Yeah.